morning everyone, I am Dr. Pradeep. So today we will be discussing the study Libretto 431 which was presented at the ESMO Congress recently. So it is a randomized phase 3 study of first-line selpercatinib versus chemotherapy and pembrolizumab and RET fusion positive non-small cell lung cancer. So we know that molecular drugs targeting mutated rearranged oncogenic drivers are standard recognized treatment in patients with advanced NSCLC. Activating RET fusions are found in 1 to 2% of NSCLC, mostly adenocarcinoma. These fusions result in ligand-independent constitutive activation of the RET pathway and leading to increased oncogenic signaling. And it is exactly a decade since RET has been designated as an activating driver oncogene in NSCLC. So we also know that first-line platinum-based chemotherapy and pembrolizumab combination is the established standard of care for patients without EGFR or ALK alterations. Based on the keynote 189, we know that ORR was 48% and median PFS was 9 months. Selpercatinib is a highly selective potent RET inhibitor that penetrates the CNS, and when it's used in the frontline, the Libretto 001, the ORR was 84% and median PFS was 22 months. So this study is a first-line phase 3 trial of first-line selpercatinib versus chemotherapy with or without pembrolizumab, which is designed to inform the optimal first-line regimen for patients with RET fusion positive NSCLC. So the current report details the findings from the first interim analysis of the trial focused on patients in the ITT pembrolizumab population. So this is a randomized multinational open-label phase 3 trial. Patients with unresectable stage 3B, 3C or stage 4 non-squamous NSCLC with RET fusion were included, and the groups were stratified by geography, East Asia versus non-East Asia, brain mets, and the choice of chemotherapy with pembrolizumab or without pembrolizumab. So initially this was eligible patients were randomized to 1:1 ratio, but after a protocol amendment it was changed to 2:1, and hence the final randomization of 1.6:1. So the experimental arm received selpercatinib at a dose of 160 mg twice daily in 21-day cycles, and the control group received chemotherapy with or without platinum-based chemotherapy with or without pembrolizumab. The basis for deciding about pembrolizumab was left to the investigator's discretion because of the doubtful role of the immunotherapy in the RET fusion positive patients. So the primary endpoints, which was PFS and BACR, was sequentially tested, first in the ITT pembrolizumab population and then in the overall ITT population, and the second endpoints were overall survival, the ORR, the duration of response, and the CNS ORR. So coming to the results, the total of 261 patients were enrolled in across 103 sites in 23 countries. In that, 201 patients were in the ITT pembrolizumab population. Or the baseline clinical demographic characteristics were well balanced within both the groups, but there were a higher number of patients in the East Asia segment who received more of selpercatinib, and the most common RET fusion partner was KF5B. So coming to the results, so if you look at the PFS by BACR, so selpercatinib had a higher median PFS which was around 24 months compared to the control group which was only 11 months, both in the intention to treat pembrolizumab population and the overall ITT population. Also, the ORR was also higher in the selpercatinib group with a response rate of 84% compared to 65%, and even the duration of response was higher. So it was for almost 24 months compared to 11.5 months. When we look at the intracranial outcomes, even there also the ORR was 82% with selpercatinib, which was higher, and almost 35% achieved complete response. The OS data was immature, and it was also confirmed by crossover because the control group patients were allowed for crossover after progression. So coming to the safety of the trial, selpercatinib comparatively had a higher rate of adverse events, and almost 70% of the patients had grade 3 adverse events compared to the control group, which were lesser. Also, the most common adverse events were mostly transaminitis and hyperbilirubinemia, which were usually managed with those adjustments. Only 10% required permanent discontinuation of the treatment. So even in the patient-reported outcomes, it was seen that patients in the experimental group had a delayed time to deterioration of pulmonary symptoms and overall physical function. So finally, the investigators concluded that selpercatinib showed superior efficacy versus chemotherapy without pembrolizumab in patients with RET fusion positive NSCLC, and the adverse events associated with pembrolizumab are generally consistent with those previously reported and typically can be managed with dose adjustment. Selpercatinib delayed time to deterioration of pulmonary symptoms and overall function. So they said that it should be considered as the first line standard of care for RET positive advanced NSCLC and stress the importance of genomic testing at diagnosis to identify possible RET gene fusions to inform optimal therapy. So we know that lung cancer truly has been the poster child for precision medicine. This is yet another practice-changing phase 3 study in this aspect. The results are obvious and they are not surprising. We have a targeted drug against drug fusion, and we wanted to know if it's better than chemo IO, and yes, what we guessed is right. It works better than chemo IO. So it also shows a high intracranial activity coupled with durable responses. So it should be taken as a new standard of care for first-line RET fusion positive NSCLC. Thank you.